Here we go.
Okay. I share the screen. I share the screen. It's okay.
No, not yet, doctor.
Okay.
Okay, now we are live, and we still have 5 minutes to go to start the webinar. I think we can. What I noticed, Dr. Latifa, from your excellent and outstanding CV, that you do sports and you do painting using the pencils, and you are also interested, or you are doing a lot of dental service to disabled people. So,
Yeah.
and of course, you are a full professor at the College of Dentistry. So my question to you, how do you manage all of this?
Yeah, I have 24 hours a day, and I say to myself how I can take enough time to learn, which is really good for me, for my life, which is beautiful to see, to say, and to learn, and to transfer and convey.
Yeah.
So
that's great. You reminded me when I was in England, Manchester University, doing my PhD. I used to play football every Saturday, and really, it was giving me a lot of energy, like refreshing every week. And like doing PhD is not an easy work or easy thing. So you
hard,
need to keep yourself like fit. You need mentally and physically. So I guess that doing exercising and enjoying the sport, that gives you maybe a lot of energy to do research, and I could see that in your CV.
Yeah, and mainly with this period of COVID-19, I think we have no choice. Yeah, we need to survive, it's really very, very difficult time ever seen. So I insist to remain and keep in making sport and making drawings and sharing my work and being with people. Even if I cannot take a coffee, it's not really easy. But we can do so many things. I hope to forget to know how to manage this period. It's really, with patients, it's really very difficult to know, because patients are afraid from getting the virus. And mainly I'm managing patients with special needs, with severe pathologies, and they have to speak to you, and you have to be mentally strong,
Yeah, right.
to manage all that. So when I finish, I go to sports.
That's great.
I run.
What do you think the most challenging things in dealing with people with a special needs?
The pathology is very severe and life-threatening, and you have to understand. I think empathy is not easy with such people with end-stage cancers and neurological diseases, psychiatric diseases. And I think when I found myself in this world of several diseases, because I've done microbiology, immunology, and infectious diseases and immuno-oncology, I found myself surrounded by that kind of people, so with severe diseases. And I'm joking, yeah. I'm giving fun to them, so that
and you're enjoying it.
Yeah.
You are enjoying it.
Yeah. I'm not making fun of the situation, but I try to help them to manage their daily life and to not to forget to be happy.
Yeah, I can see that.
Yeah.
Trying to make them happy and to give them like good dental service, that makes you like
and they forget,
person.
and they forget, at least the moment you are together, they forget their disease, and we can speak of anything just to not to focus on the pain, you know, because when we, if you wanna be, I think, unhappy, it's because of us. If you wanna be really enjoyable, it's because of us. So I think we have to be a little bit smart, and everybody is challenging, having problems, and they have to manage all that.
Okay, I beg your pardon. We are now 9 p.m. Saudi time and 6 p.m. Tunisian and the GMT time. So it's time to kick off. Hello, everyone. Good morning, good evening, good afternoon, everywhere. Tonight is a very special night. We have a great speaker, Dr. Latifa Berrezouga from Tunisia. And it's my great pleasure to introduce you tonight, Dr. Latifa. So if you allow me, with great pleasure, I introduced the webinar speaker of the 4th Excellence in Endodontics Conference, Dr. Latifa Berrezouga. Dr. Berrezouga is a full professor in medical microbiology and immunology at the Dental Faculty of Monastir, Tunisia. Prof. Berrezouga obtained her master in biological sciences and a master in medical microbiology from Paris, France. Prof. Berrezouga also attained a diploma in medical immunology at the Pasteur Institute in Paris in 1998. She joined the endodontics department at the Dental Faculty of Monastir in 2000. Prof. Berrezouga supervised more than 35 high-quality postgraduate and undergraduate theses and got most of them published in peer-reviewed journals. She has also the privilege to conduct cutting-edge research with worldwide researchers. She succeeded in identifying a new gene-involved bacterial resistance. Her research findings were published in the prestigious journal, the Antimicrobial Agents Chemotherapy Journal. Also, she has more than 30 IADR research abstracts publication in the last 5 years, which is a great record. Prof. Berrezouga is the founder and the scientific director of the Tunisian sector of the International Association for Dental Research, IADR, and she introduced the IADR prestigious and Unilever Hackathon competition and awards for young researchers, which is a great initiative. Thanks to you, Prof. Berrezouga. The Tunisian section was honored by the IADR Board of Directors on many occasions. Recently, Prof. Berrezouga has been appointed as the IADR MER Secretary. Prof. Berrezouga has been engaged in a PhD research regarding people living with HIV and HIV/AIDS to better understand the oral disease pathogenesis, hence improving people's quality of life, which is a great thing. Also, although Prof. Berrezouga has been practicing high-quality endodontics, dental trauma, and oral medicine for 20 years, her main concern has been helping and empowering young Tunisian people to develop their management skills. Thanks to you, Dr. Berrezouga, for this great move. Last but not least, Prof. Berrezouga is an excellent artist. She has several pencil drawings in the dentistry field, which I liked really, and the reproduces painters' works using simple methods. With such an outstanding passion, experience, and records, we are so delighted tonight to have you, Prof. Berrezouga, as a keynote speaker. So the stage is yours, and you can start sharing your screen. Sorry, before that, I would like to announce to all our attendees that we have a special prize for you provided from the Medical World Company. The prize is 10 Rotary kits, and the criteria for participating in this competition will be announced as a comment in this webinar. The stage is yours, Prof. Latifa.
Thank you.
And I will see you now. All best of luck.
Yeah. Thank you very much. Hello, everybody. Thank you, Professor Ahmed Malati, for this kind of presentation and for this invitation. This is the second time I'm presenting my work. So I present my work regarding, oops, there's something. Oops. I can get my second slide. I think I have to.
If you can stop sharing and go back to your presentation again and just that will be helpful. Check that it's working and then you can start sharing the screen again.
Yeah, I think I have to just start.
Okay.
Okay. So, sorry. So I was invited by Professor Ahmed Berrezouga. I'm really thankful for this invitation. And I will speak about apical periodontitis and its different facets. So to begin, apical periodontitis is a disease that can occur either in teeth, necrosed teeth, or in teeth with, for example, endodontic treatment. And regarding clinical aspects, it could be asymptomatic. For example, here it's really a discrete discoloration of the central incisor. We can never guess that there's something related to apical periodontitis unless we will take a radiograph. Here in the central incisor, it's asymptomatic, but this is a discoloration of the tooth. But it could be also symptomatic. You see here, for example, with the swelling, the buccal swelling here, the swelling relate to the molar. It's not fracture, okay? It's an endodontic necrosis. And here, the draining fistula and the draining fistula. So clinical aspects are varied and radiological aspects too. When you see here, the most etiologic origin of the apical periodontitis is dental caries, okay? So here you see two apical periodontitis. And then the second most origin is trauma, periodontal diseases, and what we call radiologic procedure. That's to say here we have a perforation, and here this is a fracture. It's a challenging really case here to diagnose a fracture. So apical periodontitis are mainly made up of cysts, abscess, and granuloma, and they are all related to what we call a biofilm, microbiological biofilm. So this microbiological biofilm will enhance, in fact, the immune system to answer by proliferating cells. And these cells, for example, in this case, this is a granuloma, for example, we can at least recognize clinically the granuloma and the cyst with experience, okay? We cannot at the first sight, in fact, diagnose this, but with experience, we can recognize the tissue related to granuloma or a tissue related to a cyst. So when you pull out a tooth, you can have this tissue closely related to the apex, what you see here, okay? It's not systematic. That means that when you extract the tooth, you can have a cyst which develop by itself. But here, for example, a tissue is closely related to the apex. So we cannot speak about granuloma or cyst because it's a histological diagnosis, but we can at least suspect on clinical and radiological basis disease. So we see here in scanner microscope this lesion. This is the apical periodontitis, and what we see here is a fibrous tissue. So I will not speak about the complication, but just to show some complications of apical periodontitis, for example, cellulitis and or severe cellulitis, and even life-threatening cellulitis. I will not speak about complications and focal infection because it's another topic, okay? Regarding my publications about outcome of initial endodontic treatment performed in 122 clinician patients, I've studied, in fact, factors, or what we call predictive factors, influencing the outcome of the endodontic treatment. And based on these factors, we have a score to, in fact, evaluate the healing of the apical periodontitis. It's healed here. When you treat, you have a healed lesion. That's to say that you have a complete regeneration of the tissue. Or you have healing lesion. That's to say the healing is on the way, but it's not complete. Or in the third situation, the apical periodontitis is healing, but it can. That's why the follow-up is important, and it's an unexpected situation, you know. So we have to follow patients at least 6 months when the lesion is small and it can heal rapidly, or at least 1 year, 2 years. It depends on the size of the lesion. So to sum up, for the initial treatment, the success rate is high. We have vital pulps, and it decreased to 88% when we have apical periodontitis. So this apical periodontitis and the biofilm and microbiological reasons, factors, contribute to the persistence of the infection inside the canal and even outside the canal, and we will see examples of persistent infections. I have an abstract, in fact, I published in the IAGR database regarding 98 apical periodontitis and the outcome, the treatment, endodontic treatment when they have apical periodontitis. As I have previously said, that the outcome of the treatment is not really successful. For example, we have just nearly 87% of success comparing to teeth with necrosed pulp or vital pulp. And among these 98 teeth with apical periodontitis, we had at least 14 lesions, persistent lesions. That to say, we have to do surgery to make the lesion healing. This is, in fact, a study published of Dr. Rim Mabrouk, which is one of my students and my colleague, actually. And we worked together on apical periodontitis and the accuracy of CBCT based on a score, from 0 to 5. And the results that we found that the CBCT is accurate in diagnosing the apical periodontitis, and mainly this three-dimensional radiograph allow us to evaluate the lesion, the extension of the lesion, expression of the cortical bone that the retroalveolar radiograph cannot do, neither the panoramic radiograph. So I will illustrate my work with some clinical cases. These patients comes to the endodontic department for an endobuccal swelling, pain. The diagnosis of acute apical abscess was done, and as you see here, the lesion related to of trauma tooth. These incisors are necrosed. So I have drained, in fact, this abscess by a coronal access, you know, and I have done the treatment, disinfection and treatment. I have the follow-up at 2 years. So at first sight, when we see the size of the lesion, someone else will say, yeah, I will go directly to the surgery. I'm not I'm not agree with that. I don't agree with that, because when we have a lesion, we have to treat first, to disinfect, and after that, if we have a persistence of symptoms, we go to the surgery. Okay, so we can disinfect, and this is the same case, you know, acute apical abscess. Here, the lesion is important and related to the central incisor, which is with an immature apex. And what I have done, I have two options. Either I made an incision and drainage, or I made a cavity access, and I have the drainage of the pus and the blood. And what I have done, I have tried to make a tissue apical plug. That to say, I have used what we call the bleeding technique, and I have put then calcium hydroxide. And in the second session, I've took my working length, and I have a hard tissue here, okay, 4 millimeter, I think. And I have, after that, obturated with MTA and resin composite. So the patient has no signs or symptoms, but even if with CBCT, we have to control the healing of the lesion, okay. This is chronic apical periodontitis, a patient which who presents several problems in one tooth, the incisor. With magnification, I have localized the main canal, which is inside of which there is resin composite when we see here radiograph. And I have localized a fourth canal with a file here. And here there's a perforation at the cervical level. So I have to, I've checked that there's no bleeding here. There's no perforation. In fact, I have to check if I can go through the resin composite. And I, in fact, eliminate the resin composite. I have disinfected canals. I have obturated the perforation using MTA, and then I make the restoration with the composite resin. This is a case of perforation. It's a young patient who was referred for a perforation during instrumentation. Okay, and you see here the importance of the lesion, periradicular lesion. So I make a disinfection of the endosis, the root canal, and I have obturated, and the magnification, I have obturated the perforation with MTA, and I didn't really succeed to work the apical part of the canal. And I have at least until now 6 years of follow-up, so no symptomatology. Always a chronic apical periodontitis, but this case is related to a central incisor with an immature apex. At that time, we have no MTA, no biodentin, so I have made the apexification technique using calcium hydroxide to get a plug. This is a calcified plug, and then I can obturate using warm gutta-perca, and the lesion healed after 2 years. Another case with this immature apex and the lesion and drain and fistula. And this is particular because with anomalies, dental anomalies such as dental invaginitis, we have to localize the invagination at the palatal side, and then to disinfect the invagination and to dress the canal with calcium hydroxide. And then under magnification, I have put MTA, and this is a healing after 2 years. So we have done studies, I and Dr. Mabrouk, regarding dental anomalies and particularly invagination and the frequency of apical periodontitis. And we found that when the invagination is related to communicating with the periodontum, apical periodontitis are more frequent than type 1 or type 2, and this is a significant difference. We have several cases of dental invaginitis. It could be a conference on this topic. So a case of traumatic prosthesis. This strange case, in fact, is a chronic apical periodontitis. What you see here are, in fact, lesions and resorption of the apex and even the roots here. See resorptions here, and calcifications. What you see here in the center incisor, calcification, and even internal resorption. I didn't succeed, in fact, to treat this incisor. I have treated these ones, and after that, I have healing of the lesions that the patients with his prosthesis, with the overbite due to prosthesis and traumatic prosthesis, we have the recurrence of the lesion. Note this when we this lesion, the initial lesion, here healing, and here the recurrence. So when we have traumatic injuries due, for example, to prosthesis or other types of forces, we will impair the healing process, and we can have recurrences of the lesion. Yeah, we treat endodontic systems, we obturate, but we have to follow up, because when patient didn't show up, we never know if the lesion healed or not. So it is very important to follow up patients and to have what everyone wanted to have, in fact, keep a functional tooth as possible, as long as possible. One of my patients, I've seen her after 70 years. Well, the molar treated, and it's still functional and healthy. Another topic, all what I have presented there is regarding non-surgical treatments. That's to say, I have an apical lesion and I can disinfect my endodontic system, and I have healing of the apical lesion, even if I have more than 1 centimeter of the size of the lesion. It's possible for the healing, so I have not to go directly through surgery. But when we go to surgery, because we have what we call persistent apical lesions or chronic extraradicular lesions due to the biofilm that surrounds the apex and even the root extraradicular lesion. So my study regarding my 8 apical lesions, we have found 14 persistent lesions made up granuloma or foreign body granuloma, cysts, actinomycosis, or cystitis. I present here some examples of these chronic apical periodontitis where persistent apical periodontitis. So the patient is coming with inadequate endodontic treatment with a lesion, and even if the endodontic treatment was done, the lesion increases in the size. Look at that, the comparison here and there, and it's well delimited, well defined here. And this increase in the size of the persistence of symptoms like drain and fistula, the surgery was performed, okay, and I have noted something bizarre here. As I said, I've stopped the surgeon. I told him I have to make this sample. I need it, and the sample, in fact, there are granular, and I sent this to histopathology, and the histopathology was the result is granulomatous, in fact, actinomycosis, and here we have healing after 1 year and no drain and fistula. So actinomycosis is a rare, persistent apical lesion. It's described in the literature under case reports, you know, and the histopathology is when we see these slides, we see here the granuloma surrounded by inflammatory cells. Here we see bacteria. Here we know bacteria, actinomyces. Here we see bacteria, etc. So it's a rare entity, but we have to think about. With extraarticular persistent lesions and drain and fistula, we have to think about periapical actinomycosis. So in that case, you see this granulomatous tissue which replace the bone because there's resorption, okay, of the alveolar bone. So when I remove this tissue, I found that there is a gutta percha exception from the apex. I go to the histopathology, and which is really important here and interesting that the diagnosis is a foreign body reaction. That to say that this immune system, when there's an extension of a material like gutta percha or other material, the immune system will respond, okay? Because biologically, we have a periapical area with cells, with vasculature, with bone. And I think that the immune system doesn't accept foreign bodies. And what the immune cells, they will surround this gutta percha, okay? They will surround the lesion, the gutta percha and the lesion to avoid that the lesion extends and decrease in size. And this is very important to remind that we need the immune system to circumscribe the lesion and avoid the extension. And in this foreign body reaction, we find cells, particular cells, macrophages, in fact, but cells with multiple nuclei, what we call multinucleated giant cells. In this foreign body reaction, we have that type of cells. So we have to understand what is happening when we have an extension of the material beyond the apex. This is very important. So for this patient, look at this huge lesion, okay? Because with a retroviral radiograph, when we see this resolution, personally, I said, no, it's really important. I have to see with a panoramic radiograph at least. So look at this lesion. It's very important. The patient presented with acute pain because this lesion is infected inside. We have pus and pressure. So what I have done at first to minimize, in fact, the pain and to decrease the pressure, I have made an incision, okay? And then I have made my excess cavities and my drainage and then disinfection. And you see here the resorption of the bone and the displacement of the roots of the incisors. And with the healing process, the root of this incisor, in fact, are positioned, okay, in their place, and we have a healing here after 2 years. So after 2 years with this big lesion, we can really see the regeneration of the tissue, all the tissue, the periodontium, the bone, etc. So the histological diagnosis is periapical cyst. And all we know that cyst is made of a cavity and an epithelium and inflammatory cells and levels of cholesterol, and this is an inflammatory reaction. And the cyst could be reinfected. We can find pus into the cyst. This is just an example to say that the periapical lesion, when it's a chronic lesion, we can find fragments of bone that are necrosed and recognized by the immune system as foreign bodies. But the immune system cannot resorb this bone. So, and this lesion should be removed by surgery. And this is the inflammation, the vasodilation of vessels, and the cells here surrounding the bone, the closed bone. We have here plasmocytes, these blue cells, nuclei, etc. So we have several types of periapical lesions. When we go through surgery, we in fact discover several types of histological entities, you know, and this is really important to understand, and probably it will make us taken probably different ways of thinking and making diagnoses and choosing our therapeutic possibilities, etc. There is no one periapical lesion. The diversity in the lesions, in the clinical presentation, and the radiological presentation. Look at this lesion. It's really unusual. This is a lesion. There is nothing, no swelling, just pain, tender pain on percussion related to this molar with the crown. And when we, the patient comes with a panoramic radiograph, I see there is a resolution here and the resolution here and something strange here, like a tunnel and something like a great lesion, very resolution. And the question I have asked is really there's a relation between that and that. This is really amazing. So I made several slices of the CBCT and I have followed the lesion. It begins by this resolution 3. And after that, you see the continuity of the lesion. It's rare to see that. And this is the distal root of the first molar. And the tooth 7 here is vital, okay? Even if the apex apices of this molar are in the lesion, okay? It's important to do vitality test to make sure that the lesion is not related to this tooth, but is related to this one. And this is very important to make the CBC analysis that will guide the surgeon, my colleague, Dr. Mohammed bin Khalifa, to make the surgery. And this is tissue that resemble to a cyst. Because of the experience of seeing several types of tissues, we can say that it can be assessed. And in fact, this lesion is indicator. I really don't understand what is happening. I don't know why this lesion is so big coming from this one. I'm making research to understand what is happening. And the lesion was filled with platelet-rich fibrin taken from the patient. And after that, after the extraction of tooth, this tooth 6, you see here this tissue that make us probably, I can say it's a cyst, because when I see this tissue, I can say probably it will be a cyst. Why this tissue is here? So I have cleaned up the root, and I've seen that this corresponds to the resolutions I have seen here. There's a perforation and the pus, and the histology intel confirms the diagnosis of a periapical cyst. Okay, a periapical cyst, that's a cyst related to an endodontic pathology, and not really a lesion independently. When we see this is a periapical lesion, it's really rare. I think it's the first time I've seen such a lesion, unusual lesion. So the patient come after 1 year for follow-up. You see the lesion here, initial lesion. This is healing after 1 year, healing of the alveolar bone of the extracted tooth. Nothing in the tooth 7 here, the second molar, healing. And I think it's really, we can speak about healing after 1 year with CBCT. So challenging cases. I made a mistake with this case. So the patient is teacher, and he came in emergency saying to me, I have fractured my teeth and I have a solution immediately. So I proposed to him to make the endodontic treatment in one session and to make bleaching and temporary recovery of the tooth with resin composite. So, and for me, it's an apical lesion, a chronic apical lesion. I have, when we would diagnose an apical lesion, I always look for a periodontal pocket. It's important to see if the lesion is originating from the necrotic pulp or originating from a pocket. So at that time, at the initial time, there is no pocket on probing. But I asked myself, why at 6 months there's no change in the lesion? But to expect that there's a fracture, frankly. 5 years later, the patient left, and the probing that I see here is a deep pocket. Okay, and I understand that I have vertical root fracture. So when you see here, this tooth is fractured, and there is a deep pocket, and there is no way to keep the tooth. So I took the tooth and I made scan and electron microscope. I went to understand what is happening, and with the scan and electron microscope, you can see the fracture line, okay, from the apex. And this fracture line is related to this apical lesion that is attached to the apex, the fracture apex, and you see this fracture going and running to the crown. This is the apical lesion with the scan and electron microscope, and this is the bifilm. This is the bifilm, you know, when you make look at that. These are bacteria, bacteria, bacilli, okay, forming an aggregation of several bacteria and a bifilm outside the root, extraradicular lesion. Unexpected. So this is a new case. I've seen this patient 5-6 months before, and the patient came to the hospital complaining with deep pain, sharp pain, injuring pain. He cannot even sleep, and I have noticed the patient came with ossibicity, okay, because the dentist asked for ossibicity, and he referred the patient to the teaching hospital. And I have noticed that there is a slight swelling here, but I can't see an obvious swelling and inside the mouth, but I can palp at least swelling and what I call indurated swelling. It's inflammatory, okay? No swelling at the palatal side. And there is something, there's a discoloration of the tooth of the lateral incisor. And when you see in the palatal side of the tooth, we see here developed sangula in the lateral teeth, and probably it could be an invagination. Why not? And in fact, these two lateral incisors, when we see the slices in CBCT, there's an invagination here and an invagination in the lateral incisor. And you have to ask the question, is really the discoloration of the tooth, it's due to necrosis of the pulp? Is this tooth, is the relation is related to the tooth? We have to ask so many questions, because when you see that type of lesion, which is very important, we have really to make several slices, and this is the invagination. And this is the type 1 invagination. And when you see the apex here, the curvature of the apex. So it's important to pre-curve the 5 when we go to explore the canal. So I tried to, under anesthesia, to open the tooth, the cavity exam, but the pain was so important that the patient stopped me, and I didn't find any other solution than to make a small incision to decrease the pressure, okay? And mainly there is no, the lesion is not outside the bone, it's still inside the bone, and the pressure is so important. So I made this incision to decrease the pressure, and in the second session, the patient came to me. I opened the canal, the main canal, and you see here the drainage of pus, and the patient was better, and there's no longer swelling. This is after 48 hours, okay? And I advise the patient to keep the tooth opened for 48 hours, and to disinfect and to make a cotton pellet, etc., to decrease this pressure. I'm not really expecting that the symptoms will disappear within several hours. And at first, I've said I have to do the endodontic treatment and then we will go to surgery. But the patient is improving and there's no longer symptoms. So I have done with my colleague, Dr. Mohammed Sahbi Al-Ayuni, the endodontic treatment. And this is the CBCT, the follow-up 6 months after. This is really amazing. The healing process is on the way. You see here bone. This is the obturation, and bone at the central level here, and bone regeneration of the tissue. And I said to the patient, yeah, it's okay. Everything is okay. You don't need now, right now, to do to think about bleaching agent for the discoloration tooth, etc. We have just to focus on the healing process, and you will not go through surgery. I'm really sure. Probably 1 year or 2 years to have the full healing of the lesion. This is really unexpected, unusual, challenging, and that's why when we have a periapical lesion or apical periodontitis, we have not to say, yeah, I will do my endodontic treatment and everything will go great. I'm not really sure. Each patient is a patient, an individual patient, and the immune system helps us to enhance the process of healing, and tissue regeneration is really very important. So the fact I see these type of lesions, different types of lesions, different ways of treatments, and the process of healing. I have lesions, maxillary lesions, very large lesions that heal without surgical intervention, mandibular lesions that cannot heal without a surgical intervention. And I'm not, I don't know why I'm thinking about gravity. I don't know. I got this idea about gravity. This is really amazing. The immune system, the solar system. Gravity is, I'd like really to, I have asked the question about gravity, and I think there's something related to gravity concerning our physiological biology in general, and the occurrence of disease and healing, etc. I don't know why. but I got this idea about gravity. I have to make research regarding gravity and apical lesions. So these are examples of my patents, and my first virtual running, half marathon, and to keep safe, you have to do so many things, you know, all what I can love and appreciate and share. And thank you.
Thanks a lot, Prof. Latifa. Interesting and informative presentation, actually. And I'm sure all our members enjoyed the presentation and found it very useful. I think we're going, maybe we still have, I can't see the comments if we have some questions or not, but myself, I have two questions. You mentioned and you showed the case where the apical lesion due to the extruded cotebertia, and after the pathology inspection, it was an immune system reaction to a foreign body. So my question here, and it might be a deep question, or does it really immune system reaction to the foreign bodies or to the bacteria or biofilm that foreign body has? Sorry.
I think that the
Sorry,
immune
but
system.
because my question, the reason for my question, because in principle, cotebertia meant to be compatible by the body.
Yeah, not all the time, you know. It depends. Yeah, the material could be contaminated by bacteria. Okay, but even the material is composed of components, chemical components, you know, and it will react as what we call antigens. Okay, antigens, because the immune system reacts to everything, and not against bacteria alone. You know, everything, water, space, molecules, chemicals, physical stimuli, and microorganisms. Okay, so the immune react when there's a stimulus, whatever be the stimulus. Okay, but the bacteria, when the immune system reacts against bacteria, probably there's a different way for the reaction, because bacteria will enhance first the innate immune system with an inflammation, etc., and the humoral immune system. And there are what we call recognitions between the cell and the some patterns of the organism, but recognition of any stimulus, whatever the composition.
I can see. Thank you. Within the same regard, usually I receive the same question all times, that doctor, I have here in this case extruded bioceramic sealer or MTA sealer, and do I need to do the surgery? Do I need to do anything? Because it's a huge amount of extruded material, even though it's biocompatible. So what do you think about that?
Biocompatible, the word, I'm not really sure. It's, yeah, biocompatible, because it's it has been tested. But if the extruded material is not, for example, near a nerve, or there is no reaction, the patient is asymptomatic, we don't need to do surgery. I think we have to learn to not extrude material, than to extrude material and go through surgery. That's why in apical lesions, and particularly in chronic apical lesions, we have resorption of the apex, even if we cannot see it clearly in the radiograph. Biologically, there's resorption of the apex, and we have to ask a question, what will be the working length? When we do the obturation, we have all sealers extruded and gutta percha. And sometimes I ask myself, what are we evaluating this working length? In most obturations, we have sealers and gutta percha outside the bed, some MGA. Our evaluation working length, and in fact, we are not respecting the apical area. So I think we have to respect the periapical area and to work, disinfect all the canal system to the working length, apical working length, radiologically or biologically. I cannot really estimate this working length biologically, but we can be at 1 millimeter from the apex when we will obturate. But I'm not really sure, even if the immune system tolerates, the immune system can tolerate foreign bodies, you know, and people are living with foreign bodies with no reaction because the immune system has the ability to circumscribe, you know, to surround and to construct a layer which is made of fibrous. This is a resistant layer that cannot be, that will circumference the lesion to avoid the extension of the lesion. That's why when we have the true cyst, I didn't speak about the basis and true cyst, etc. When we have true cyst, we cannot reach the lesion because the true cyst is self-sustained, you know, and independent from the rest of the canal. So even if with a long file, we wanted to perforate this layer, it's so resistant. And the truth is, when we cannot disinfect and reach the cyst, we have to make the endodontic treatment and go through surgery. But if you have a lesion in direct contact with the canal system, we can disinfect, and the lesion, we have to switch off the lesion. It's pathological inflammatory reaction, or we know that inflammation is the first step for healing. So we have just to switch this pathological inflammatory reaction to a healing inflammatory reaction. This is this difference, in fact, to better understand what is happening with the inflammation for healing and inflammation with destruction.
In the same regard, like, because the same point, what usually I answer, like, part of it, I think, and here I need your experience. Does the amount of the extruded material matter? Because I believe, like, when it is too much, that means there is a greater chance of the body not to tolerate that extruded material.
Yeah, sure.
Small amount, like in puff, you know, like all of us like the sealer when it goes a little bit as a puff. So we say that's okay. But when it is like large amount, even like it is biocompatible sealer, I think this is what I believe, that the body will not tolerate. What do you think?
Yeah, because the immune system will be overloaded by the amount of the sealer, overloaded, because when you have small amounts of extruded materials, the immune system can manage the small amount. But if you have a large amount, I think that the immune system will be overloaded, and cells and the material will take the place of the periapical region. So the cells has to eliminate all that, you know, elimination by phagocytosis. It's not really easy for the cells to phagocytose, to digest all these material. So it takes a lot of time. That's why we have to follow up. If there's no symptoms, we have to follow up. Okay. If there's a risk that the patient will not show up, etc., we will go through probably surgery. But personally, I'm against these extrusion of materials and maybe full amounts that could make a pressure on a nerve or go in the sinus. And we have many pathologies related to materials in the maxillary sinus and materials that making pressure on the nerve, etc. And we have problems of sensibility, etc. I think that we have to pay attention when we treat mandibular molars and maxillary molars, especially.
So we need. So we agree both that, and we go. I'm going to stress again on all our members and colleagues. Please, a buff is okay if it happens, but please don't try to get the buff sealer. Okay, I have to from two kind doctors. Is keeping open tooth as drainage safe to enter more bacteria as 48 hours?
Generally, when I have, for example, an abscess or cellulites, etc., generally I don't keep tooth opened, okay? Nor for 1 hour, and nor for 24 hours, etc. This patient is a particular situation, you know, and the lesion is unusual, okay, related to a lateral incisor with this invagination inside, and this lesion takes so many years to develop because the invagination is a microscopic invagination, you know, and we have small amounts of saliva and bacteria that goes through this invagination, so microscopic, and will take a lot of time. So the lesion is extending into the bone and taking and replacing the bone by the resorption, okay? And this lesion is made of cells, of cells, and it increases in size. And when it increases sufficiently in size and the bone, cortical bones, become thin, there's a swelling, palpable swelling, but I didn't see the swelling, but the pressure is so important that the patient cannot sleep. Painkillers are not efficient, antibiotics, everything. So when I have make this incision, that's just to decrease pressure. And I'm not inside the lesion, okay? And when I have opened the tooth, the amount of pus is so important, and going through a small canal, I said to myself, I have to let this cavity access opened, not open to the oral environment. The patient has to disinfect the cavity access with, for example, peroxidine, and to put a cotton pellet after eating, okay? And for 48 hours, because there's a large amount of pus inside the lesion, and to make a pressure, you know, to make a pressure and to allow the pus going through the canal. But generally, I'm not really for leaving open cavity access to the oral cavity. I'm microbiologist, because you have a reinfection of the system. This is a particular situation. What I have inside the lesion is several times more infected when we compare to the oral cavity, okay? So for the most septic situation, for the less septic, I think.
I have another question from Dr. David Ayad. In retreatment cases, do you use only, or do you dress calcium hydroxide only?
Not only for retreatments, you know, even if I have initial treatments with apical periodontitis, in fact, in the literature, there's no significant difference between treat and teeth in 1 or 2 sessions. This is not the problem. My problem is a microbiological one, you know. I wanted to disinfect the endodontic system sufficiently and to obturate. So retreat or not, I think when we have an initial treatment, even with a periapical lesion, I think we have nothing to lose when we dress the canal with calcium hydroxide, because we know that ions of the calcium hydroxide will go through the dentin, and the pH is so high that bacteria cannot tolerate that type of pH and cannot survive in this pH. So I make disinfection either with in initial treatments or retreatments.
This is one aspect that we might understand from the question, but I think maybe the other aspect of the question, like whether do you use other type of dressings, like or only you rely on calcium hydroxide as an intracanal medication? I think I understood from the question.
Yeah, I rely on calcium hydroxide, frankly, because it's a high pH is largely sufficient to kill bacteria inside the endodontic system. Mm-hmm. I think it's very efficient with a pH of 12. I think it's as sufficient as sodium hypochlorite.
Mm-hmm. Another question: after how much time can we establish that there is healing occurring, and what are the signs?
There is what? Sorry?
I'm going to repeat the question. After how long can we establish that there is a healing occurring, and what are the signs?
Yeah, it depends on.
Here they are talking about the radiographic signs of healing.
Even the clinical signs, we have also clinical signs, but it depends on the situation, okay? If I have, for example, we have not to underestimate small periapical lesions, okay? Because small periapical lesions could be persistent and extraradicular lesions, and we need a surgical intervention, okay? So we have not to underestimate lesions, the periapical lesion. It depends on the situation. I have a patient with a periapical lesion and a drain and fistula. I can understand it's a chronic periapical lesion, okay, with a drain and fistula. So if I treat, I disinfect and I treat, the first thing I have clinically is a few days after the drain fistula will disappear, okay? This is the first sign, clinical sign. This is a first positive clinical sign. And then after that, there's no longer symptoms. At least we have to make a follow-up of 6 months, because we can have healing after 6 months, and mainly for small periapical lesions that are not persistent ones, okay? And after that, we can go after 4, even 5 years if there's surgery or large periapical lesions. You have seen the case of the large periapical lesion. After 2 years, we have almost complete healing. So it depends on the situation. At least 6 months.
In this regard as well, you showed one case that the healing process started and there was bone formation, and I think it was a lower anterior tooth. And after 1 year or 2 years, again, the apical lesion recurrent again. Okay, so. Yeah. So here I have 2 questions. First of all, because now, like they are claiming that we need to revise the guidelines for follow-up, which is agreed on 4 years. But some clinicians and some colleagues, they are claiming that, okay, we need to revise these guidelines. Okay, this is one point. And the other point is, what do you think the reason for the recurrent lesion, or what happened exactly? What do you think?
Really, if you have the chance or lucky that the patient is motivated and he will show up for the follow-up, because it's not really easy task for a patient. It's a constraint, etc. So when I have a patient after 17 years, it's really because she's still living in the same place. We have the chance to meet, etc.
We are lucky.
So, yeah. So I think this is a particular situation because there are so many unexpected events, And that's why we have not to be so sure of ourselves and speak to the patient. Yeah, I do that, and you do that, I do that, and that. And they come to you, doctor, you said to me that, and it didn't happen. So we have to be aware that particular situation can occur. This is a published case in my in the paper, and the patient showed up really spontaneously because I thought that the healing occurred, and it remains a little bit for the bone to regenerate and the periodontal ligament. But after that, she came, and hopefully I keep all my radiographs, etc. I keep clinical files of my patients, so I returned to the first radiograph for the lesion and the healing after I think 1 year, and I said everything is okay. And after that, this comes with a recurrence lesion. So frankly, it's not as frequent, and probably because we are not following up sufficiently patients. So we treat, and we don't know what will happen after. So we don't know what will happen because follow up, even if you see in the literature, not all patients will come after 2 years, 4 years. Yes. It's difficult for the patients. But my explanation is what I have when I look close to this radiograph. I have 2 canals, and I have materials outside the canal, and I think the canal, the apex is destroyed, you know, because the canal initially was so small, and with the this traumatic instrumentation and preparation with taper, I think L6. So we have not to enlarge for to obturate, and this is the point. I think we have just to disinfect and keep the initial anatomy of the endodontic system. So this material outside the apex, I'm trying to understand, even me, because I didn't take this part for analysis, unfortunately. So I think that when I have made the disinfection and then the obturation, we are never sure that we have 0 bacteria. There's probably bacteria surrounding the extruded material. So when cells came for regeneration from the periphery to the apex, I think, and I'm not really sure, that they came close to this biofilm. And I think something happening, probably the pathogenicity of microorganisms, bacteria, switch the immune cells to induce a pathological inflammation. And there's resorption, unfortunately. Maybe it's an explanation. If I got the chance to cut off this apex and made an analysis, histopathological or scan and microscope, maybe I found a biofilm that could explain at least the interruption of the healing process. Really, it's amazing. Like the patient that he has a recurrence because he has another bite, because there's a traumatic prosthesis. When you have a healing process and you interrupt this healing process by a force, and which is not controlled, you will switch this healing for the pathological inflammation.
Yeah.
I think so. We have to do research, in fact.
Yeah. Just to sum up this, like whenever it's a healing process, that doesn't mean 100% healing. That we agree on that. And as far as I understood, you agree on the current guidelines that the follow-up for the ideal follow-up for endodontic treatment is 4 years. Right?
Yeah. Yeah.
I have another question. how we can remove calcium hydroxide. It is difficult to remove it completely. So how do you manage this problem? So,
No, at all. No, we can never complete nor bacteria completely, nor calcium hydroxide. Um, uh,
what do you
sometimes,
do for enhancing removal, Prof. Latifa?
yeah, I think that with new techniques of irrigation, activation, I think there's a benefit from these techniques to better remove either calcium hydroxide or other paths that antibiotic paths, for example, for regeneration and endodontic regeneration. But I think that pathology is so diverse and is our knowledge and our therapeutic are matching with our current environment, you know. And with new technologies, we discover new ways to treat and better treat. But I'm not really sure that we can treat everything because there are so many things that we don't know. And if I was a webcam, a small webcam, I will enter inside the endodontic system. And like we enter into the bloodstream, and
Yeah,
we will see so many things.
yeah.
So
Amazing things.
yeah, we are losing magnification. It's not really so impressive because when I see things by scanning electron microscope or electron microscope, and so I don't know, magnification 1500, you see so many things. So I think that the future will be with greater magnification to see better and to remove better and to treat better.
Yeah, and for this, personally, I use very tiny ultrasonic tips with the irrigation. And definitely that will be under magnification, as Prof. Latifa mentioned. When you see, you are able to remove more. I think we don't have more questions. If anybody wants to ask, I'm sure Dr. Latifa will be more than happy to answer your questions later. Just ask or type your question in the comments, and Prof. Latifa will answer. Thanks a lot to Prof. Latifa for this excellent webinar and the on-format presentation. We are really delighted to have you, and we hope that we have you again in the near future. Thanks a lot.
Thank you very much, Professor Ahmed Rati. It's a great pleasure for me, and it's a great honor. I'd like to thank all the team with whom I work, the residents, young persons with whom I work are really, I hope for them a great future, and I'm thankful to my colleagues and friends, Professor Mohammed Ben Khalifa, Professor Dr. Mohammed Sahbi Al-Ayuni, and Cyril Lakhel. Thank you. She's an active person. Nice to meet you, and hope to meet you again.
Yeah,
thank you all. Yeah,
thank you all for attending this webinar, and thanks for the whole team working with us. Thank you, everyone, and see you again in another.
Bye-bye. Yeah, thank you.
Bye.